Welcome to the deep dive. Today we're plunging into something you carry with you every second of every day,
Yeah.
covering your entire outer self, yet probably don't give it nearly enough thought.
And you should, because it's surprisingly substantial. Did you know that in an adult, your skin has an area of 1 to 2 square meters
Wow.
and can weigh between 15 and 20 kilograms? It's
Yeah.
not just a thin wrapping.
20 kilograms. That fact alone is, well, it's incredible. Okay, let's unpack this amazing source we have. It's a detailed medical text focusing on the skin and subcutaneous tissue, and see what fascinating insights we can find about the body's largest organ. Our mission in this deep dive is to really understand its complex structure, its vital functions, and then explore some of the key conditions and challenges it can face, drawing exclusively from the information this text provides.
Right.
It's far more than just a barrier. It's a dynamic system.
Absolutely. This source makes it clear it's a sophisticated interface with the world, built from layers and specialized cells, performing functions critical for our survival beyond just keeping everything inside.
So where do we begin? The text lays out the fundamental architecture, starting with two main layers.
Yeah.
The outer epidermis and the inner dermis,
Yeah.
sitting right on top of the subcutaneous fat.
Exactly. And the detail it gives is fascinating. The epidermis, that outer layer we see and feel, is remarkably thin, making up only about 5% of the skin's total thickness.
Only 5%? Wow, considering it's the front line, right?
Yeah.
And this thin layer has distinct sublayers itself.
It does. The text lists 5 distinct layers, or strata, starting from the deepest and moving outwards. The basalis, spinosum, granulosum, lucidum, and corneum.
Great.
This is where the journey of the keratinocytes, the main cells of the epidermis, takes place.
The keratinocyte journey. Okay, what does that look like?
Well, they start dividing down in the basal layer, the stratum basalis. As new cells are formed, the older ones are pushed upwards through the other layers. As they move, they differentiate, they change their shape, their composition, becoming tougher and flatter. By the time they reach the outermost layer, the stratum corneum, they've lost their nuclei and, other internal structures. They become these tough, flat bags of keratin.
So dead cells, basically.
Dead, flattened cells, yeah, forming a protective, waterproof shield that's constantly shedding.
That's an incredible transformation just within that 5%. And skin color comes from cells in this layer, too.
Yes. That's the job of the melanocytes, which are also found in the basal epidermis. They produce melanin,
Pigment?
the pigment exactly, that gives our skin, hair, and eyes their color. Melanin is then transferred to the keratinocytes moving upwards, and this pigment is crucial for protecting the DNA in our skin cells from damage caused by ultraviolet radiation, from the sun.
And it's not the number of melanocytes that differs between people.
No, the text confirms that. Ethnic differences in skin color are primarily due to variations in the amount, the type, and the distribution of melanin produced and transferred.
Okay. Not the overall number of melanocytes.
Got it. There's also a protective layer right on the surface.
Right. The source describes the surface being coated with a mixture of secreted substances and microorganisms, forming what's called the acid mantle.
Acid mantle.
Yeah, this creates a slightly acidic pH environment that helps protect against colonization by harmful bacteria and fungi.
Okay, so that's the thin but mighty 5%. What about the other 95%? That's the dermis.
The dermis. Yeah, this is where you get the bulk of the skin's thickness and strength. That's primarily connective tissue.
Right.
The text divides it structurally into two layers. The more superficial papillary layer,
Papillary.
which is delicate collagen and elastin fibers and is rich in small blood and lymphatic vessels. And then the much thicker, deeper reticular layer,
Okay.
that's composed of coarser, more densely packed collagen fibers, layered kind of parallel to the skin surface, providing significant structural support.
And the way the epidermis and dermis connect isn't just a flat boundary, is it? No, not at all. It's described as a fascinating 3D wave-like interdigitation. You have these downward projections of the epidermis called reiriges that lock into upward projections of the dermis called dermal papillae.
Okay.
These dermal papillae contain tiny capillary loops and nerve endings, providing nourishment to the epidermis and housing many of the skin's sensory receptors.
And that wavy connection must make it stronger, resist shearing.
Exactly. It increases the surface area for nutrient transfer and helps resist those shearing forces that could separate the layers. Very clever design.
The text also mentions specialized cells within these layers beyond keratinocytes and melanocytes.
Yes, important players in the skin's immune and sensory functions. You've got Langerhans cells.
Immune cells?
Immune cells, yeah. Scattered throughout the epidermis, acting as sentinels that capture foreign invaders and alert the rest of the immune system. Then there are Merkel cells involved in light touch sensation.
Yeah.
And Meissner's and Pacinian corpuscles. Those are key mechanoreceptors detecting different types of pressure and vibration.
Fascinating. And what about the structures that start in the epidermis but extend down into the dermis? Hair, glands.
Right, those are the adnexal structures. Hair follicles, sebaceous glands, and sweat glands are all crucial components that span both layers.
Okay.
And the text points out something vital here. These structures contain keratinocytes within their ducts.
Ah, like a backup system.
Exactly. It provides a built-in backup. If the skin surface is damaged, new epidermis can grow not just from the edges of a wound, but also from these deeper structures. It facilitates reepithelialization.
That's a really smart biological design for repair.
Right.
Tell us a bit more about the glands.
Okay, so sebaceous glands are usually attached to hair follicles, and they secrete sebum.
Some oily stuff.
Yeah, an oily substance that helps lubricate the skin and hair.
Yeah.
This is a holocrine secretion, which means the entire cell actually breaks down to release its contents.
Wow.
And you also have the tiny erector pili muscles attached to hair follicles, the ones that cause goosebumps.
Right, and the sweat glands.
Two main types mentioned. Eccrine sweat glands are distributed almost everywhere, and their primary role is thermoregulation.
Cooling us down.
Through evaporative cooling, yes. They're also involved in emotional sweating, like on your palms before a speech, you know.
Oh, yeah.
Then apocrine sweat glands are found in specific areas like the axillae and groins. They become active at puberty, are influenced by hormones and emotion, and their secretion becomes odorous when bacteria on the skin break it down.
Ah, okay. So this structure, the layers, the cells, the adnexal structures, it all adds up to quite a significant organ, as you mentioned, with the weight and area.
Absolutely. 1 to 2 square meters, 15 to 20 kilograms. And the text highlights how its thickness varies remarkably across the body. It's thinnest on the eyelids
Thanks, Ed.
and thickest on palms, soles, and the back. It also changes with age, while the dermis is much thicker than the epidermis, sometimes up to 40 times thicker.
Wow.
It starts to thin after about age 40.
That gives us a detailed map of the structure. Now, let's talk about how this massive organ is supplied and what its core jobs are. Blood supply first.
Right. The source introduces this concept of angiosomes, essentially 3D blocks of tissue. Each block has its own dedicated arterial supply and venous drainage vessel.
Like little supply zones.
Pretty much. And these blocks can communicate with each other via smaller connecting vessels called choke vessels, which often lie within the muscles underneath.
And how do arteries reach the skin specifically? Is there a standard route?
They take different routes, actually. They can either travel through or perforate underlying muscles, or they can run directly within the layers of fascia from the deep tissues up towards the surface.
Okay.
Once they reach the skin, they branch out and form multiple interconnected networks, or plexi, at different levels. Subfascial, fascial, subdermal, dermal, and then a really fine network just below the epidermis.
But there's a crucial point about that outermost layer, the epidermis, regarding blood supply, isn't there?
Yes, and it's a key takeaway from the text. The epidermis itself is completely avascular.
No blood vessels at all.
None. Its cells receive all their oxygen and nutrients purely by diffusion from the rich vascular plexi in the dermis just below it.
Huh. How does the blood drain away then?
Through a system of both valves and unvalved veins. The unvalved veins in the subdermal plexus are interesting.
Why is that?
They allow blood flow to actually oscillate back and forth. It helps to balance flow and pressure across different areas of skin. Blood then drains deeper into the valved veins.
The text makes a really interesting point about the sheer volume of blood the skin can receive. It sounds excessive.
It does, doesn't it? It notes that the skin has the capacity for a blood supply that's anywhere from 20 to 100 times greater than what's needed for its basic metabolic needs.
Or even for temperature regulation.
Right. Much more than is needed even for that.
That sounds like massive overkill. What's the purpose of all that excess supply then?
This is where the insight comes in. That extra capacity isn't wasteful. The text states it's specifically designed for the restitution of mechanical integrity after trivial injuries.
Trivial injuries, like everyday stuff.
Exactly. Think of everyday scratches, stretches, minor compressions, or mild thermal insults. The skin has this huge capacity to quickly repair itself from that baseline damage.
Built-in rapid patch-up for daily wear and tear. That's fascinating.
Precisely. Now, the text clarifies that this excess supply isn't sufficient for full-thickness wound healing, which requires more complex processes like primary closure or developing granulation tissue.
Right.
But this ability to tolerate relative ischemia, reduced blood flow, is why skin can be used so successfully in things like skin grafts and tissue expansion for reconstruction.
Ah, that makes sense. So beyond structure and this impressive blood supply, what are the big jobs the skin performs that this source highlights?
Well, it lists several vital functions. First and foremost, it's a barrier mechanical protection from trauma, protection from radiation like UV, and protection from pathogens aided by that acid mantle we mentioned. It's crucial for regulating our body temperature and maintaining water balance. It also has an excretory role, eliminating small amounts of urea, electrolytes, and some drug metabolites through sweat.
And it's like a chemical factory and a huge sensor. Is that fair?
That's a great way to put it, exactly. It has significant endocrine and metabolic functions. Skin cells possess receptors for various hormones and neurotransmitters, and they can even produce, activate, or metabolize hormones.
Like vitamin D.
Including the production of cholecalciferol, a form of vitamin D when exposed to UV light, yes. And absolutely, it's a massive sensory organ packed with nerve endings and specialized corpuscles detecting pain, pressure, vibration, and movement. What's fascinating here is how much more the skin does than just protect us. It's a complex factory and communication hub, constantly interacting with the environment and the rest of the body.
It sounds less like just a covering and more like its own ecosystem. Knowing how it's built and what it does makes you appreciate it. But what happens when this complex system is challenged? The text explores problems arising from both outside and inside.
Right. It starts with external challenges like radiation damage. The source explains how both ultraviolet, UVR, and ionizing radiation can damage the DNA in our skin cells,
How?
specifically affecting a key tumor suppressor gene called p53. This disrupts the cell's ability to repair DNA errors or trigger programmed cell death, apoptosis.
So damaged cells can survive and multiply.
Potentially, yes, allowing them to grow uncontrollably. UVR also suppresses the local immune response in the skin, which further facilitates the development of skin cancers.
UV is often talked about in different types, A, B, C.
Yes, the text mentions UVA, UVB, and UVC. UVA penetrates deeper into the skin, longer wavelength. UVB has higher energy per photon and is a primary cause of sunburn.
Both bad, though.
Both UVA and UVB contribute significantly to oxidative damage, accelerate skin aging, and are major causes of skin cancer. Melanin helps to absorb UV radiation, reducing its impact.
Which is why darker skin has some protection.
Exactly. Lower susceptibility to UV-induced cancers. The stratum corneum itself, clothing, sunscreens, even clouds and pollution offer some level of protection.
And infrared radiation, IR. What does that do?
That primarily generates heat. Cumulative exposure can contribute to thermal burns over time.
Okay. The text then shifts to problems originating within the body, particularly congenital and genetic disorders that manifest in the skin.
Yeah, and this section really reveals how the skin can act as an early warning system for systemic conditions. For example, in neurofibromatosis, a genetic disorder causing tumors to grow on nerves.
Right.
The skin shows some of the earliest, most characteristic signs.
Like those coffee with milk spots, cafe au lait spots.
Precisely. In NF1, the more common type, affecting about 1 in 4,000 births, you'll see the text says more than 5 smooth-edged cafe au lait spots. Plus soft subcutaneous neurofibromata, these nerve tumors under the skin, freckling in unusual places like the armpit or groin, and Lish nodules in the iris of the eye.
And NF2 is different.
NF2 is rarer and involves tumors on nerves in the brain and spinal cord. But those skin signs of NF1 can prompt investigation for a much broader, potentially serious condition.
There's another genetic condition linked to skin cancer risk, Gorlin syndrome.
Yes, nevoid basal cell carcinoma syndrome, or Gorlins. It's an autosomal dominant disorder, mutation in a tumor suppressor gene.
And the risk.
Individuals with the syndrome have a remarkable 90% lifetime risk of developing multiple basal cell carcinomas.
90%.
Yeah. The text also notes specific physical features associated with it, like prominent brow ridges, a broad nasal root, rib abnormalities, and small pits on the palms and soles.
Xeroderma pigmentosum sounds devastating.
It is a very severe condition. It's an autosomal recessive disorder affecting DNA repair mechanisms.
So they can't fix damage from UV.
Exactly. Patients are profoundly sensitive to UV light and have an over 2,000-fold increased risk of skin cancer. They experience premature aging of the skin, develop numerous cancers from a young age,
Oh, wow.
and sadly face a high mortality rate. many succumbing to the disease by their early 20s, according to this source.
Other syndromes cause different types of skin growths.
Gardner syndrome, a variant of familial adenomatous polyposis, is autosomal dominant and linked to multiple epidermoid cysts and fatty tumors, lipomata, in the skin.
Okay.
The text also mentions Ferguson-Smith syndrome, a rare autosomal dominant condition where individuals develop multiple squamous cell carcinomas that actually heal on their own.
Heal on their own.
Yeah, and notably, the text says they are not linked to sun exposure.
It's striking how many different genetic pathways can impact the skin. And the skin can also reflect other diseases happening elsewhere in the body.
Yes, absolutely. The skin can be a mirror for internal health. The text provides examples like necrobiosis lipoidica and granuloma annulare,
Which can indicate
diabetes mellitus, and pyoderma gangrenosum, which is often seen in patients with inflammatory bowel disease or rheumatoid arthritis.
So these are signs on the skin prompting investigation for systemic conditions.
Exactly.
The text also discusses issues with sweat and fat. Hyperhidrosis first.
Hyperhidrosis is simply excessive sweating, typically from the eccrine glands. It can be functionally and socially debilitating for people.
I can imagine. Treatments.
Options mentioned range from antiperspirants and botulinum toxin injections to surgical sympathectomy for very severe cases.
And lipodystrophy, loss of fat.
Yes, the loss of fat tissue, either localized or generalized. The text lists causes like long-term insulin use, treatments for HIV, or complications after organ transplant. It notes that options like fat grafting can be used for treatment.
Okay, inflammatory conditions are also detailed. Hidradenitis suppurativa sounds unpleasant.
It's a chronic, painful condition, primarily affecting skin areas with apocrine glands, axillae, groins.
What happens?
It starts with blockage of hair follicles, leading to infection, often by Staph aureus and P. acnes. You get recurrent painful abscesses and the formation of sinus tracts and scarring.
Causes?
It has a genetic component and is associated with factors like obesity and smoking. Management can involve lifestyle changes, medical therapies like antibiotics or anti-androgen drugs, and in severe cases, radical surgical removal of affected tissue.
And pyoderma gangrenosum, which we heard can be linked to IBD?
Yes. This condition is characterized by the rapid onset of very painful skin ulcers that typically have a unique appearance. A purple undermined border.
Undermined.
Yeah, like the edge is sort of scooped out underneath. It's thought to be due to an overactive immune response.
And treatment.
While associated with systemic diseases, the ulcers themselves usually respond well to steroid treatment. But the text gives a strong caution here. Surgery is generally not indicated for pyoderma gangrenosum.
Why not?
It can actually make the ulcers much worse. It's a key point.
Good to know. Okay, infections are a significant threat to the skin.
Definitely. The text covers a range, from localized to rapidly spreading and non-necrotizing to necrotizing, meaning tissue-destroying.
And the proscippers.
Big time. Localized or non-necrotizing infections often respond to antibiotics alone. However, necrotizing infections, even if localized, require surgical debridement in addition to antibiotics.
And spreading necrotizing infections.
The text stresses these are life-threatening surgical emergencies. They require immediate aggressive resuscitation, powerful IV antibiotics, and urgent radical surgical removal of all affected tissue.
Radical debridement. Okay, impetigo is a common one in children, right?
It is. That's a superficial bacterial infection, usually staph or strep, highly contagious, forms blisters that rupture and leave characteristic honey-colored crusts.
Treatment.
Generally washing and topical or oral antibiotics. Pretty straightforward, usually. Erysipelas is a deeper but still superficial strep infection, often on the face, typically associated with a break in the skin. Presents as a sharply demarcated, bright red, swollen area with fever. Prompt antibiotics are crucial.
Cellulitis is more generalized, less defined borders.
Yes, exactly. It's a bacterial infection. Strep pyogenes, or Staph aureus, are common culprits involving the deeper skin and subcutaneous tissue. You see an expanding, painful, red, swollen area, often with fever and malaise.
And sometimes red streaks.
Yeah, sometimes you can see red streaks tracking along lymphatic vessels, which is lymphangitis. Antibiotics and elevating the limb are standard treatment.
And the emergency you mentioned, necrotizing fasciitis. This sounds terrifying.
It is a critical surgical emergency. It's a rapidly spreading infection, often involving multiple types of bacteria working together synergistically.
What triggers it?
There's typically a history of minor trauma or infection initiating it in about 80% of cases. It can quickly progress to septic shock.
What are the warning signs?
The text lists classical signs to watch for. Swelling that extends beyond the visible redness, the affected area feeling woody hard to the touch, difficulty defining tissue planes on palpation, pain that is disproportionately severe for the apparent injury, the appearance of blisters or vesicles, and sometimes a crackling sensation under the skin called soft tissue crepitus.
Crackling, like air.
Yes, from gas produced by the bacteria. And lymphangitis is often absent, unlike in regular cellulitis.
And the response has to be immediate.
Immediate resuscitation, IV antibiotics, and radical surgical debridement to remove all dead tissue. Despite aggressive treatment, mortality is tragically high, ranging from 30 to 50% according to this source.
Just awful. Purpura fulminans also sounds terrifying.
It's rare, thankfully, but extremely severe. It involves rapid, widespread clotting within the small blood vessels, leading to skin necrosis and hemorrhagic infarction.
Clotting in the vessels.
Yes, which cuts off blood supply. This can quickly escalate to septic shock and DIC, disseminated intravascular coagulation. It's typically seen in young children, often after a bacterial infection like meningitis or a viral one like varicella.
What does it look like?
You see a rash of small dots, petechiae, that rapidly merge into large purple or black areas, ecchymoses, and hemorrhagic blisters, culminating in hard, black, dead tissue called eschars. It frequently results in extensive tissue loss, requiring amputations, and carries a high mortality rate of 40–50%.
Unbelievably severe. Okay, moving away from infections, the text also covers various skin and soft tissue cysts, milia.
Milia are tiny, hard cysts made of keratin, very common in newborns or on sun-damaged skin in the elderly. Little white bumps.
And epidermal cysts, often called sebaceous cysts.
Right, though that's technically incorrect. They are lined with skin cells, epidermal cells, and are typically fixed to the skin with a visible central pore, a punctum.
What if they get inflamed?
They become inflamed or infected, they need draining. But to prevent them from coming back, they require complete surgical excision once the inflammation has settled. You have to get the whole sac out.
And there are specific types in certain areas like eyelids or scalp.
Yes, like meibomian cysts on the eyelid margin, and tricholemal or pillar cysts, which are very common on the scalp, often multiple, and arise from hair follicle sheaths. Pathologists distinguish these from epidermal cysts based on their lining. This section really highlights how the skin is both a target and a mirror for problems originating outside and inside the body. You know, it raises an important question. How do we differentiate between conditions that can sometimes look quite similar on the surface?
That question is crucial, especially as we transition to what might be the most concerning category for many people, skin tumors.
Indeed. The text covers a spectrum here, from benign lesions to premalignant changes and outright malignant cancers. It points out the increasing incidence globally, especially in white-skinned populations.
And the impact.
Well, while skin cancer is the most common malignancy overall in white individuals, melanoma, though rarer, is responsible for over 75% of skin cancer deaths. So, high stakes.
Let's start with the reassuring ones, the benign lesions. Seborrheic keratosis.
Basal cell papilloma, commonly known as seborrheic keratosis, yeah. They're those warty, often brown lesions that look like they are stuck onto the skin. They arise from the basal layer and vary greatly in appearance.
And warts.
Papillary warts, or verruca vulgaris, are benign tumors caused by HPV infection. Common warts.
Freckles and lentigos.
Freckles or ephelides are flat, pigmented spots where melanocytes are normal in number but overproduce melanin, usually due to sun. Lentigos are similar pigmented macules, often from sun damage or associated with syndromes, more stable than freckles.
And then there are moles or naevi. The text details different types based on location.
Exactly. Naevi are basically clusters of nevus cells, which are modified melanocytes. The type depends on where these cells are clustered.
So junctional.
Junctional naevi are flat or slightly raised and pigmented, with cells clustered at the border between the epidermis and the dermal-epidermal junction, common in childhood and adolescence, and they can progress. To compound naevi, yes. These have clusters at the junction and also deeper in the dermis. They often appear more raised, more prominent in adolescence.
In intradermal.
Intradermal naevi have cells only in the dermis. They're usually soft, slightly elevated, and often less pigmented, more common in adults. Kind of fade over time.
A Spitz nevus sounds like it could cause confusion. Why is that?
It can. Spitz nevi are benign nodules, often reddish-brown or pigmented, that can grow quite rapidly initially, common on the face and limbs, especially in children.
So the rapid growth looks suspicious.
Exactly. Because of their appearance and sometimes rapid growth, they can be mistaken for melanoma, particularly under the microscope. They used to call it juvenile melanoma. So an excision biopsy is often needed just to be absolutely sure of the diagnosis.
And the text mentions spindle cell naevi. These sound different.
They are less common. Dense black lesions, often on the thighs of women, containing spindle-shaped cells at the junction. The source notes they may have malignant potential, so they warrant careful evaluation.
Halo naevi are where a pale ring forms around a mole. What's happening there?
Yes, this depigmentation is due to the body's immune system attacking the melanocytes around the nevus.
Usually benign.
Usually occurs around a benign mole, yes. But it's important to know that a halo can sometimes appear around a malignant melanoma, though less commonly. Halo naevi are also associated with the skin condition vitiligo.
Some pigmented spots are tied to specific syndromes, like the cafe au lait spots again.
Right. Cafe au lait spots, those light brown, coffee-colored macules when you see multiple, they're associated with conditions like neurofibromatosis type 1 and McCune-Albright syndrome. They are more noticeable in individuals with darker skin.
And nevus speckless, speckled.
Nevus speckless, or speckled lentiginous nevus, is essentially a cafe au lait spot with darker speckles within it. While generally benign, its speckled appearance can sometimes raise concern for malignancy, so observation is often recommended. Malignant transformation is rare, the text says.
Mongolian spots are a type of birthmark seen in infants.
Yes, these are congenital blue-gray macules, most commonly found on the lower back or buttocks of infants, particularly in Asian, Hispanic, and African populations. They usually fade and disappear completely by around age 7.
Blue naevi.
Also benign, have a bluish tint due to the depth of the pigment in the dermis. More common in children, often on the extremities and face.
And naevi of Ota and Ito. These are deeper, too.
Yes, these are deeper dermal melanocytic collections, like birthmarks, but deeper. Naevi of Ota presents as blue or gray pigmentation on the face, following the distribution of certain trigeminal nerve branches. 4 times more common in women, often in Asian and African descent.
And Ito.
Naevi of Ito is similar, but occurs in the shoulder region and can sometimes be seen alongside Naevi of Ota.
There are also benign tumors arising from the skin's adnexal structures, the glands and follicles.
Yes, the text lists several examples. Trichoepithelioma, which can look very similar to a basal cell carcinoma. Pilometrixoma, a hard, calcifying tumor from hair matrix cells, common in kids. Tricholimoma.
That one has a risk.
Small risk, yeah. About a 10% risk of a BCC forming within it. Adenoma sebaceum are facial papules associated with tuberous sclerosis. Rhinophyma.
The enlarged nose in rosacea.
Exactly. The bulbous nose seen in end-stage severe acne rosacea caused by sebaceous gland hypertrophy. The text mentions that occult BCCs can sometimes be found within that tissue, and various benign sweat gland tumors are also listed.
So many different benign growths are possible. But the text also covers lesions that are considered premalignant. What does that mean exactly?
These are lesions that aren't cancer yet, but have a significant potential to develop into cancer over time. They need watching or treating.
Like extramedullary Paget's disease.
Yes, that's one example. It's an adenocarcinoma cancer originating in glandular tissue, but it's confined to the epidermis in areas rich in apocrine glands, like the armpits or groin.
What does it look like?
It can look deceptively like eczema or a fungal infection. The text warns that up to 25% of cases are associated with an underlying invasive cancer deeper down. Surgical excision is the main treatment.
Giant congenital pigmented naevi were also mentioned as premalignant. These are the very large birthmarks.
Yes, very large moles present from birth, caused by an extensive collection of nevus cells extending deep into the skin and fat.
And the risk.
Because of their size and depth, they're considered melanoma precursors. The lifetime risk is debated, often quoted around 3–5%. But a key fact from the text is that about 1/3 of melanomas diagnosed in childhood arise within these giant naevi. The risk decreases with age, though.
Management.
Involves considering screening for associated brain and spinal cord pigmentation, neurocutaneous melanosis, and often surgical removal for both cosmetic reasons and to reduce that cancer risk.
The term atypical or dysplastic nevus seems to cause some confusion. Can you clarify?
The text highlights this well. The term is used in both a clinical sense, what the doctor sees, and a histological sense, what the pathologist sees under the microscope.
So they don't always match up.
Exactly. Clinically, an atypical natus meets specific criteria like having variegated color, an ill-defined border, an uneven surface, or being larger than 5 mm. Dysplasia is a histological finding of abnormal cell changes in the mole under the microscope. Not all moles that look clinically atypical show dysplasia histologically, but some do.
And these increase risk.
Yes. These lesions, especially when multiple, increase melanoma risk. If you have more than 5 clinically atypical naevi, your melanoma risk is increased 6-fold according to this source. And in families with AMM-HEM syndrome, familial atypical multiple mole melanoma syndrome.
Which involves lots of these moles.
Yes, numerous atypical moles. The risk of melanoma is considered 100% in those families, requiring lifelong screening. This section really highlights a crucial point for both patients and clinicians, understanding that there's a spectrum, and being able to differentiate a common harmless mole from one that warrants closer inspection or is actively changing towards malignancy.
It sounds like the key is recognizing change or features that stand out from your other moles, which leads us to the malignant lesions, the skin cancers themselves.
Right. And as we noted, skin cancer is the most common cancer overall in white populations, about 1/3 of all cancer diagnoses annually. While melanoma is less frequent, its higher mortality rate means it accounts for the majority of skin cancer deaths.
Starting with the most common type, basal cell carcinoma, or BCC.
BCC. It's a slow-growing, locally invasive tumor arising from cells in the basal layer of the epidermis and hair follicles. It's strongly linked to UV exposure, particularly intermittent, intense sun exposure earlier in life.
But it rarely spreads.
Almost never metastasizes, that's a key feature. But it can be locally destructive if not treated. Over 90% are the nodular type, but the text also mentions more aggressive, high-risk subtypes.
What are some key points about its epidemiology from the source? Who gets it?
UV radiation is the strongest risk factor, mainly middle-aged to elderly individuals with a history of excessive sun exposure. 95% occur between 40 and 80. Interestingly, about 1/3 appear in areas not typically exposed to the sun.
Really? Like where?
The text doesn't specify locations for the non-sun exposed ones, but implies areas usually covered. Other factors include exposure to chemicals like arsenical compounds or coal tar, chronic heat exposure, and certain genetic syndromes like Gorlins. BCCs are almost exclusively seen in white-skinned people and are more common in men.
Does it start from a specific precursor lesion, like an AK for SCC?
No, the text states BCCs usually arise without a clear precursor lesion. The risk seems proportional to the initial dose of carcinogen rather than cumulative exposure over time.
Macroscopically, how would you recognize one? What's the classic look?
The classic nodular type, which is 90% of them, is described as having a pearly or translucent surface, often with visible fine blood vessels called telangiectasia running over it.
Early look. Okay, other types.
There are also superficial variants, which are flatter and more spreading, red and scaly sometimes, and infiltrative or morphaic subtypes, which can be subtle on the surface, maybe look like a scar, but spread aggressively under the skin.
Microscopically, what do they look like?
Under the microscope, you see nests of cells that look similar to basal epidermal cells. The cells at the edge of these nests arrange themselves in a characteristic single layer called palisading.
Palisading, like a fence.
Exactly, like a fence around the nests. These cells divide slowly, explaining the slow growth, but local spread is common if not removed completely.
Prognosis varies based on the type and location. You mentioned high risk.
Yes, the text defines high-risk BCCs. These are larger ones, over 2 centimeters. Those located near critical structures like the eyes, nose, or ears where invasion is dangerous. Recurrent tumors, those in patients who are immunosuppressed, or those with certain aggressive microscopic subtypes like micronodular or infiltrative patterns.
How are BCCs managed? Primarily surgery.
Surgery is the primary treatment, yes. This involves surgical excision with a margin of surrounding normal tissue. The margin size is tailored, typically 2-15 millimeters, depending on the BCC's characteristics and risk level.
What about Mohs surgery?
For BCCs with ill-defined margins or those in cosmetically sensitive areas where preserving tissue is crucial, like the face, Mohs micrographic surgery is often used. This technique allows for precise removal by checking the margins under the microscope during the surgery, step by step.
Any non-surgical options?
Radiotherapy can be used for elderly or frail patients who aren't good surgical candidates. Topical creams like imiquimod or 5-FU are sometimes used for superficial BCCs.
And complete removal is really important. You stress that.
Absolutely. The text emphasizes this. If a BCC is removed and there's microscopic involvement of the margin, meaning cancer cells are right at the edge under the microscope, the recurrence rate within 2 years is 33%.
A third comeback.
Yeah. And if the margin was visibly involved during surgery, the recurrence rate can be as high as 67%. So clear margins are key. Follow-up is recommended for high-risk tumors, those with incomplete excision, or patients with multiple BCCs or predisposing syndromes.
Okay. Moving on to the second most common type, cutaneous squamous cell carcinoma, or SCC.
SCC. This is a malignant tumor arising from the keratinizing cells of the epidermis. Unlike BCC, it has a higher potential for metastasis, though still relatively low for most types.
Associations.
The text highlights its association with cumulative UV exposure, chronic inflammation, immunosuppression, and chemical carcinogens.
Epidemiology seems strongly linked to lifetime sun exposure more than BCC.
Yes, SCC is strongly correlated with total lifetime sun exposure, more so than intermittent intense sun. It's much commoner in white-skinned individuals, particularly those living closer to the equator, and more common in men.
Beyond sun.
Beyond sun, it's linked to chronic inflammatory conditions like old scars, that's called a Marjolins ulcer, chronic sinus tracts, burns, areas of chronic swelling like in lymphedema. Immunosuppression is a major risk factor, causing more aggressive SCCs.
Other factors.
Radiation, chemical carcinogens like arsenic or tar, certain HPV types, and tobacco use, which the text says doubles the risk.
The text talks about a continuum here, meaning some lesions are now seen as precursors to SCC or early forms.
This is an important concept. Actinic keratoses, AKs, those rough, scaly spots on sun-damaged skin, represent areas of partial thickness dysplasia in the epidermis. The basement membrane is intact.
So not cancer yet.
Not invasive cancer yet. They can wax and wane, but up to 20% can progress to invasive SCC over time. A cutaneous horn is essentially an AK with a very thick, hard keratin cap. About 10% of these have invasive SCC at their base.
And keratoacanthomas, they grow fast.
Keratoacanthomas, KAs. They are rapidly growing, dome-shaped nodules with a central keratin crater. They were previously considered separate, maybe benign, but the text notes they are now generally viewed as a specific type of self-healing SCC.
So they are SCCs.
Yes, keratoacanthoma-like SCCs is how the text refers to them. Excision is usually recommended anyway because the differential diagnosis includes more aggressive SCCs that don't self-heal, and surgical removal results in a better scar than waiting for self-resolution, which can take months.
And Bowen's disease is SCC in situ, meaning stuck in the top layer.
Exactly. This means there is full thickness dysplasia throughout the epidermis, but the cells haven't broken through the basement membrane into the dermis yet. It appears as a slowly enlarging red, scaly patch.
Where does it occur?
Anywhere on the skin. On the glans penis, it's known as erythroplasia of Queyrot. Because it's non-invasive, topical treatments can be effective, although surgery is also used, especially for larger or recurrent lesions.
Macroscopically, SCCs can look quite different from each other.
Yes. The text describes them as variable. They can be smooth nodules, warty, verrucous, cauliflower-like, papillomatous, or ulcerating. When ulcerated, they characteristically have a hard, raised, averted edge and are surrounded by inflamed, indurated, hardened skin. It's important to consider SCC in the differential diagnosis for many persistent, suspicious skin lesions.
Prognosis for SCC depends on several factors. What makes one high risk?
The text lists several independent variables that influence the risk of recurrence or metastasis. Depth of invasion is key, deeper is worse. Less than 2 millimeters rarely metastasizes, but over 6 millimeters has about a 15% metastatic risk.
Size matters too.
Surface size, yes. Larger than 2 centimeters is worse. Also, the histological grade, how abnormal the cells look under the microscope. Microscopic invasion into surrounding lymphatics or nerves is high risk. Location matters. Lesions on the lips or ears have higher local recurrence rates. Those on the extremities tend to have worse outcomes than the trunk. The underlying cause is also relevant. SCCs arising in scars or previously irradiated skin have a higher potential to metastasize, and whether the patient is immunosuppressed that allows tumors to invade further and faster.
So overall risk varies a lot.
Huge variation. Overall metastasis risk is quoted as 30%, typically to regional lymph nodes, and local recurrence is about 20%. A good histopathology report is crucial, detailing depth, invasion pattern, and margin clearance.
How is SCC managed?
Yeah.
Surgery again.
Surgical excision is the definitive treatment because it allows for the most accurate assessment of the tumor's characteristics and confirmation of clear margins.
How wide are the margins?
Excision margins are tailored to the size of the lesion. Generally 4 millimeters for lesions smaller than 2 centimeters and 1 centimeters for those larger than 2 centimeters. For high-risk lesions, particularly with concern for lymphatic spread, addressing the regional lymph nodes is part of the overall strategy.
Follow-up.
Most recurrences or metastases occur within 5 years, so the text suggests routine follow-up beyond that period isn't usually indicated unless it's a high-risk case.
Okay. And finally, the one that causes the most concern for many, cutaneous malignant melanoma.
Melanoma. This is a cancer of the melanocytes, the pigment-producing cells. Can arise in the skin, but also mucous membranes, the eye, or the membranes covering the brain and spinal cord.
Incidence is definitely on the rise globally. We hear that a lot.
Yes. The text links this partly to increased recreational sun exposure and migration patterns of white-skinned populations to sunnier climates.
And its impact.
While it accounts for less than 5% of all skin malignancies, it's responsible for over 75% of skin cancer deaths. It's particularly notable as the most common cancer diagnosed in young adults aged 20-39.
Young adults.
And the most likely cause of cancer-related death in that age group. The text mentions ongoing research into specific patterns of sun exposure cumulative versus blistering sunburns and the role of vitamin D, but still emphasizes sun protection as the most important preventative measure.
What are the main risk factors identified in the source?
They are numerous. Genetic predispositions, like certain syndromes, a personal history of melanoma, having a first-degree relative with melanoma,
Moles and sun exposure.
having a large number of moles, the type says over 30 sun-acquired naevi OR, a history of 5 or more significant blistering sunburns before age 16, having fair skin or red hair, living near the equator, excessive UV exposure from sun or tanning beds, and immunosuppression, which increases the incidence dramatically 20-30-fold.
Any other factor?
The text also notes that male gender and solitary living are correlated with thicker melanomas at diagnosis, while higher socioeconomic status is correlated in women. Interesting points.
Interestingly, most melanomas don't arise from existing moles, do they?
That's right. The text states that 80-90% of melanomas arise de novo brand new and previously normal-looking skin. Only about 10-20% develop from pre-existing naevi.
Which moles are most likely to change?
Atypical naevi, certain types of junctional naevi, and giant congenital pigmented naevi are the most likely precursors mentioned.
What are the classic features that might suggest a mole is changing or is a melanoma? The ABCDEs.
Essentially, yes, though the text summarizes it slightly differently. Look for changes in size, shape, becoming irregular, color, variation within the lesion, or new colors appearing like black, blue, white, red, thickness, elevation, or developing an ulcer. Also, the appearance of satellite lesions, smaller pigmented spots nearby, and later signs like tingling, itching, or discharge. Basically, any change in a mole or a new spot that looks different from your others.
There are 4 common macroscopic variants described. Superficial spreading.
Superficial spreading melanoma, SSM. It's the most frequent, making up 70% of cases. It often arises in a pre-existing mole and initially grows horizontally along the epidermis relatively slowly.
The radial growth phase.
Right. Before starting a more rapid vertical growth phase down into the dermis, which is often indicated by nodularity appearing.
Nodular melanoma.
Nodular melanoma, NM, is about 15%. More aggressive, tends to appear suddenly and grow rapidly, often without a significant horizontal phase. Frequently occurs on the trunk or head and neck, more common in men. Usually a sharply defined dark papular nodule, though up to 5% can be a melanotic, lacking pigment.
Lentigo maligna melanoma.
LMM accounts for 5-10%. Develops slowly over many years as a variegated brown macule on chronically sun-damaged areas like the face, neck, and hands of the elderly. Strongly linked to prolonged, intense sun exposure, more common in women. It has less metastatic potential until it develops a vertical growth phase. Used to be called Hutchinson's melanotic freckle.
An acral lentiginous melanoma, ALM. Where does that occur?
This variant occurs on the palms, soles, and under the nails. It's relatively rare in white-skinned populations, 2-8% of melanomas, but is the most common type in individuals of Afro-Caribbean, Hispanic, and Asian descent, 35-60%.
What does it look like?
Typically a flat, irregular patch that appears later in life. About 25% are amelanotic, making them tricky to diagnose as they can resemble fungal infections or benign growths like pyogenic granulomas.
What about under the nail?
Subungual. The text notes that melanoma under the fingernail, subungual melanoma, is usually SSM, not ALM, and stresses that biopsy of the nail matrix is needed. A classic sign of subungual melanoma is Hutchinson's sign pigmentation, spreading from under the nail onto the adjacent nail fold and nail dystrophy. That helps distinguish it from benign racial pigmentation.
Any other less common types mentioned?
Briefly, yes. A melanotic melanoma, which lacks pigment, difficult to recognize, sometimes presenting initially as a metastasis from an unknown primary, maybe even from the GI tract. Desmoplastic melanoma, often on the head neck, tends to grow along nerves, requires wide excision because it recurs locally. Can also be a melanotic.
Microscopically, what marks melanoma? What defines invasion?
Malignant changes begin in the melanocytes in the basal epidermis. Melanoma in situ is confined to the dermoepidermal junction. The horizontal growth phase is when malignant cells spread outwards along the junction. The vertical growth phase occurs when the cells invade downwards into the dermis.
And depth matters most.
The text emphasizes that greater depth of invasion correlates directly with a higher potential for metastasis. Deeper is generally worse prognosis.
Management starts with evaluation and biopsy.
Yes. History and physical exam are crucial to identify the primary lesion and check for any signs of spread to local lymph nodes or distant sites. The definitive diagnosis and initial treatment involve an excision biopsy with a small margin, 2-3 millimeter, that includes the full thickness of the skin and a cuff of subcutaneous fat.
Always excision, or sometimes just a piece.
Usually full excision. Incisional biopsies, taking just a piece, are sometimes used for very large or disfiguring lesions, like on the face, where immediate wide excision isn't feasible or desirable before diagnosis. Observation with serial photography and dermoscopy by an experienced clinician is also an option for some equivocal lesions instead of immediate biopsy.
Staging seems critical for prognosis. What's the key measure?
It is critical. The Breslow thickness, measured microscopically from the top of the granular layer down to the deepest part of the tumor, is highlighted as the most important prognostic indicator in the absence of detectable lymph node metastases.
So for early stage, depth is king.
Pretty much. The full AJCC staging system is more complex, incorporating lymph node status and distant spread, but the text notes that specialists refer to detailed tables for precise staging.
Investigations like sentinel node biopsy are mentioned. What's the purpose?
Sentinel node biopsy, SNB. It's a procedure where the lymphatic drainage pathway from the primary melanoma site is mapped to identify the very first lymph node the cancer cells would encounter if they were spreading.
To find hidden spread.
Exactly, to detect occult microscopic spread to the lymph nodes that isn't clinically apparent. The text states that offering SNB to patients with tumors of a certain thickness, T2A stage or greater in this text, is considered critical by the author. It helps stage the patient accurately and informs treatment decisions. Further investigations for higher stages, T3A+, are guided by clinical findings.
Local treatment is always surgery. Wide excision.
Yes, surgical excision is the cornerstone of local treatment. Lentigo maligna, being melanoma in situ, requires excision. For invasive melanoma, wide excision margins are used. The width is determined by the Breslow thickness. 5 millimeter for in situ, 1 centimeter for invasive tumors less than 1 millimeters deep, and 2 centimeters for deeper tumors.
Wider isn't better.
The text notes that wider margins, for example, greater than 2 centimeters for deeper tumors, haven't been shown to improve survival.
What about regional lymph nodes if they might be involved?
Well, the likelihood of metastatic spread to regional lymph nodes is proportional to the Breslow thickness. The best management strategy for regional nodes has been debated for over a century.
Elective removal versus waiting.
Right. Studies of elective lymph node clearance for patients with only micrometastasis found on SNB, meaning the node looked normal clinically and had tiny deposits under the microscope, haven't shown a survival benefit.
Why might that be?
Possibly because the SNB procedure itself removed the only involved node in those cases. However, the text states that completion lymphadenectomy, removing the rest of the nodes in that area after a positive SNB, still remains the optimum approach for achieving regional disease control, provided the patient accepts the associated risks and morbidity. It's a complex discussion with the patient.
And adjuvant therapy after surgery to prevent recurrence.
Yes. For patients with more advanced disease, stage 3 or 4, or sometimes high-risk stage 2, particularly those with genetic mutations like the BRAF V600 mutation found in about 50% of melanomas, targeted therapies are available. These block specific pathways like the MAPK pathway.
And immunotherapy.
Immune checkpoint inhibitors, which harness the body's own immune system to fight cancer drugs like ipilimumab, nivolumab, pembrolizumab, have shown significant benefit for metastatic or unresectable melanoma. Recent adjuvant therapy trials in stage 2 patients have demonstrated improved relapse-free survival, and some are starting to show overall survival benefits as well. Big advances there.
Prognosis factors. Lymph nodes seem paramount if involved.
Breslow thickness is the best predictor of survival for patients with stage I disease, the early localized melanoma without lymph node involvement. A higher mitotic index, how fast the cells are dividing under the microscope, also indicates a poorer prognosis. The text says this is actually more significant than whether the tumor is ulcerated or not.
But if nodes are involved,
Then the presence of lymph node metastases becomes the single most important prognostic factor, outweighing all primary tumor characteristics. The number of affected nodes and whether the cancer has spread outside the node capsule, extranodal extension, are strong predictors of outcome.
and clinically involved nodes is a bad sign.
The text mentions that if lymph nodes are clinically involved, meaning you can feel them or they show up clearly on scans, 70–85% of those patients unfortunately already have occult distant metastases that haven't been detected yet.
Finally, the text briefly touches on a rare but aggressive tumor, Merkel cell carcinoma.
Yes, this is a malignant tumor arising from Merkel cells, those touch receptors, usually seen in elderly individuals, and it's notably 4 times more common in women, according to the source. Treatment involves wide local excision with generous margins, 25–30 millimeter, followed by radiotherapy. It's aggressive.
Wow, it's clear that skin cancer is not a single entity at all. There's so much variability in how they look, how they behave, and how they're treated. It's fascinating and, yeah, a bit sobering how much detail is involved.
It absolutely underscores the need for careful examination and diagnosis, and highlights that the skin, while resilient, is vulnerable to serious challenges from both within and without.
Which brings us to the final section this text covers, vascular lesions and wounds. How does it classify vascular lesions?
The text helpfully classifies vascular lesions into 2 main biological categories: tumors or malformations.
Okay, what's the difference?
Vascular tumors, like hemangiomas, are characterized by rapid proliferation of endothelial cells, the cells lining blood vessels early in life, followed by spontaneous regression or involution, they shrink away. Vascular malformations, on the other hand, are structural abnormalities of blood vessels. They are typically present at birth, grow proportionally with the child, and do not involute. They stick around.
So the common strawberry nevus is a tumor then because it goes away.
Yes, the capillary hemangioma, often called a strawberry nevus, is the most common vascular birthmark and fits the tumor category. About 90% are present at birth or appear shortly after, often on the head and neck.
They grow first.
They grow rapidly in the first year, then involute slowly, with about 70% resolved by age 7. They are 3 times more common in girls than boys and tend to occur in fair-skinned individuals. Very large ones can sometimes trap platelets, potentially leading to clotting problems. That's Kaspar-Merit syndrome.
And vascular malformations are different because they don't go away. They just grow with you.
Correct. They affect boys and girls equally, are always present at birth, they're sometimes deep and not immediately visible, and grow throughout life in proportion to the child's growth.
Any complications?
Depending on the type, stasis in large venous malformations can cause blood clotting issues. Abnormal blood flow and low flow malformations might lead to underlying bone hypoplasia, underdevelopment, while high flow ones can cause soft tissue and bone hypertrophy, overgrowth.
The text lists some common birthmarks specifically. Salmon patch.
The salmon patch is a pinkish macule, often on the nape of the neck, the stork bite, or eyelids, caused by persistent fetal circulation and usually fades by age 1.
Hemangiomas we covered. Port wine stains.
Capillary vascular malformations, also known as port wine stains, are less common, about 20 times rarer than hemangiomas. They are flat, purple-red patches, often on the head and neck, believed to be caused by defective nerve control, leading to localized blood vessel dilation. Laser treatment is often effective, and they can be associated with certain syndromes. They don't fade.
There are also vascular lesions acquired later in life. Cherry spots.
Campbell de Morgan spots, also called cherry angiomas, yes. Small, benign, red papules on the skin, essentially tiny arteriovenous fistulae at the dermal capillary level. Very common in older individuals, particularly on sun-exposed areas.
Spider naevi.
Spider naevi are small central arterioles with radiating capillaries resembling a spider. They can appear and disappear spontaneously, often during puberty or pregnancy, resolving postpartum, or be associated with chronic liver disease. Laser can treat them.
Pyogenic granuloma sounds a bit more dramatic. Grows fast, bleeds.
It does. It's described as a small, maybe 0.5 to sub 1.5 centimeters raised soft red nodule that grows rapidly and tends to ulcerate and bleed easily after even minor trauma. The text suggests it might be a subtype of hemangioma. Excision with minimal margins is typically recommended.
Gliomas tumor.
painful.
A glomus tumor is a small, painful purple nodule, often found under the fingernail or toenail, arising from a subcutaneous arteriovenous shunt structure. It causes disproportionately severe pain, especially in response to cold. Can be tricky to diagnose when under the nail.
What about malignant vascular tumors, angiosarcoma?
Angiosarcoma is a rare, highly aggressive cancer of the cells lining blood vessels. A variant called lymphangiosarcoma can develop in tissues affected by chronic lymphedema, like an arm after mastectomy. They are characterized by rapid proliferation and early spread throughout the body. Very serious.
And Kaposi's sarcoma, linked to immunity.
Kaposi's sarcoma is another malignant proliferative tumor of vascular endothelial cells. Historically seen in elderly Jewish men, it's now most commonly associated with immune compromise, such as in organ transplant recipients or individuals with HIV infection. It's strongly linked to infection with human herpes virus 8, HHV8.
What does it look like?
Presents as red-brown, hardened plaques or nodules that can ulcerate. Radiotherapy is a common treatment.
Finally, the text covers wounds, starting with congenital ones.
Right. Cutis aplasia congenita is a rare condition where an infant is born with an absence of skin and underlying soft tissue, sometimes even bone defects. Perry-Romberg disease is a rare, progressive condition involving atrophy, wasting of skin, soft tissue, and sometimes bone on one side of the face. It can be quite disfiguring, a variant of scleroderma.
And spina bifida involves the skin too.
It can, yes. It results from a failure of the neural tube to close completely during fetal development, leading to bony defects in the spine, most commonly in the lower back. Spina bifida occulta is a minor form with only a bony defect, often marked by a dimple or patch of hair on the skin overlying it.
And more severe forms.
Spina bifida cystica involves protrusion of the meninges or spinal cord itself through the bony defect, creating a sac covered by thin skin or membrane that's a meningocele or meningomyelocele. Management is multidisciplinary, focused on protecting the exposed neural tissue and managing associated neurological issues.
Acquired wounds are more common, like pressure sores.
Pressure sores, also called bed sores or pressure ulcers. Areas of tissue necrosis caused by prolonged, unrelieved pressure on the skin, particularly over bony prominences.
How do they form?
The text notes they cause cone-shaped areas of tissue loss, with the widest damage occurring deep down near the bone. They are common in hospitalized patients, the elderly, individuals with spinal cord injuries, and those with decreased sensation. The underlying cause is pressure exceeding capillary pressure, leading to tissue ischemia, lack of oxygen, and cell death.
And muscle is more vulnerable than skin.
Muscle and fat are actually more susceptible to pressure damage than skin, yes. Management focuses on relieving pressure special mattresses, frequent repositioning, optimizing the patient's overall health, nutrition, treating anemia, and preventing infection. Surgery may be needed for debridement and reconstruction, though recurrence is a significant problem in patients with ongoing risk factors like paralysis.
Ulcers are another type of wound, just a break in the surface.
An ulcer is defined as a discontinuity of the epithelial surface with destruction of the epithelium and an underlying base of granulation tissue. The text mentions that the appearance of the ulcer's edge can provide clues to its cause.
How so?
Nonspecific ulcers have shelving edges. Tuberculous ulcers can have undermined edges. Syphilitic ulcers can be punched out. And malignant ulcers arising from BCCs or SCCs have characteristic rolled or heaped up everted edges, clues for the clinician.
Sinuses and fistulas are also discussed. What's a sinus?
A sinus is a blind-ending tract, often originating from a deep cavity, like an abscess or cyst, that extends to the skin surface. The tract is typically lined with granulation tissue, not proper epithelium.
What causes them?
Sinuses can be congenital or acquired due to things like retained foreign bodies, chronic infection like osteomyelitis, chronic inflammation like in Crohn's disease, malignancy, or inadequate surgical drainage of an abscess. Treating a sinus requires addressing and removing the underlying cause. It's crucial to biopsy the wall of a persistent sinus to rule out malignancy or specific infections like TB.
And a fistula connects two things.
Yes, a fistula is an abnormal tract connecting two epithelium-lined surfaces that normally shouldn't be connected. The tract itself is often lined with granulation tissue, but can become epithelialized over time if it's chronic.
Examples.
They can be congenital, like a tracheoesophageal fistula connecting the windpipe and esophagus. Or acquired, like an enterocutaneous fistula between the bowel and skin, often seen in Crohn's disease or after surgery. Or an arteriovenous fistula between an artery and vein, sometimes created for dialysis access. Management is directed at the underlying cause, creating the abnormal connection. This section really rounds out our picture, showing how the skin is not just a protective layer, but one that can be profoundly affected by congenital issues, physical forces like pressure, chronic disease processes, and infections, manifesting in a huge variety of wound types.
It really drives home the point that the skin is intricately connected to the rest of the body's systems and overall health. What a journey. We've really taken a comprehensive journey in this deep dive, haven't we? Starting from the incredible detail of the skin's microscopic layers and specialized cells,
The epidermis and dermis.
exploring its vital roles as a barrier, regulator, factory, and sensor, digging into the many ways it can be challenged by genetics, environment, infection, and disease.
Yeah, the infections and inflammatory conditions were quite something.
And finally, looking at the surprising complexity involved in recognizing everything from common moles to aggressive cancers and understanding different types of wounds.
It's clear from this text that the skin is a far more dynamic and critical organ than many people appreciate. The level of detail provided on how different conditions manifest and are managed really highlights just how much ongoing research and clinical expertise are dedicated to understanding this vital interface between us and the world.
This wasn't just an anatomy lesson. It's a reminder that our skin is a constantly active system, responding to internal and external cues. It makes you look at something as simple as a scar or a freckle with a completely different level of understanding, doesn't it?
It really does. And thinking back to the sheer biological capacity of the skin, its intricate structure, and that generous blood supply dedicated to repair.
That point about the skin having 20 to 100 times more blood flow capacity than its basic needs. Yeah, that stuck with me. Specifically earmarked for rapid repair after everyday trivial injuries.
Yes, it's such a clear example of biological systems building in redundancy and capacity, specifically for resilience and healing. It's prepared for minor damage.
So here's a thought to leave you with, drawn only from the insights in this source. Given the skin's extraordinary capacity for repair, evident in its excess blood supply designed for restitution after trivial injuries, what does this tell us about the fundamental biological drive towards healing, even when faced with complex pathology like tumors or severe life-threatening infections?
That resilience is deeply embedded.
So what does this all mean for how you view your own skin? Something to think about.